Hi, and thanks for joining us at this Medtronic Diabetes webinar with guests Dr. Mark Forbes and MiniMed 640G insulin pump user Gareth Collins. My name is Stuart Mitchell, and I'm here with the marketing team at Medtronic Diabetes in Sydney. I'll be your host for tonight's Q&A on type 1 diabetes and insulin pump therapy. Let me first introduce our guest, endocrinologist, Dr. Mark Forbes. So Dr. Mark Forbes is the Clinical Director of Diagnostics, Emergency and Medical Services at Gold Coast Health and Hospital Service. He's also the Staff Specialist in General Medicine and Endocrinology. He's trained initially in South Africa prior to moving to the UK, where he was trained in endocrinology. He has worked on the Gold Coast for 8 years. He's actively involved in the commissioning of the new Robina and Gold Coast University hospitals, both as a clinician and more recently as the clinical director. Mark is passionate about improving diabetes care through the education of medical students, postgraduate doctors and nurse specialists, plus sharing knowledge around type 2 diabetes with GPs. Current clinical interests include the clinical management of young adult diabetes, complex type 2 diabetes, the use of insulin pumps and technology in the treatment of diabetes, general endocrinology and acute general medicine admissions. Thanks for joining us, Mark.
Thanks, Stu.
And our next guest is Gareth Collins. Gareth has had type 1 diabetes for 25 years. He switched from multiple daily injections to an insulin pump because he still had highs and lows throughout the day and night, which particularly affected his productivity at work. His daughter Shiloh also has type 1 diabetes. Diagnosed at just 29 months, Shiloh uses the MiniMed 640G insulin pump with SmartGuard. Fewer injections, 24-hour monitoring, and plenty of dips in the pool have given more freedom to the Collins family. Thanks for joining us, Gareth.
Thanks for having me.
All right. So thanks everyone for submitting your questions upon registration. We've had a great range of questions come through, so it should be a great evening here with our two guests. As a reminder up front, you can also submit your questions throughout the live webinar. Best way to do this is using the Google Hangouts in the comments section. You can tweet using the hashtag 640GWebinar or post a question or a comment to our Facebook page, which is Medtronic Diabetes Oz. All right, so let's kick things off with the first question, and I'll ask this to you, Gareth. What were your initial concerns about using an insulin pump? And what convinced you to change from injections?
Yeah, I think this is quite a common concern. One of which I talk to many people about is literally having a device attached to you 24/7. People are unsure of how it's going to sit, what it's going to do, and how it's going to change their lives. What really convinced me to change along the way was after 16 years of multiple daily injections and around 30-odd thousand injections, I was getting tired of doing it. I could feel myself going into sort of a downward motion around it, and I needed a change. So with work with the endocrinologist at the time and suggestions to go on a pump, really moved forward and made it a lot easier. So now in the last 8 years, it's only been around 1,000 injections compared to the 15,000 it would have been on MDI.
Great, thanks for that, Gareth. That's a massive change in injections. Across to you, Mark, for the next question, and a great question here on general pump information. So just seeking general information on pumps: cost, pain, convenience, control, level of difficulty. I've been using pens for 12 years now with quite bad control, but a little scared of change. We're also trying for a child. What are your thoughts on this question here, Mark?
Yeah, all really relevant issues and things that we spend a lot of time exploring and thinking around in the clinic when we have a patient who we're considering moving to a pump. I'll tackle the piece around pregnancy or family planning because I think that's a crucial time for any woman who has diabetes. It's really important that your control is as tight as you can get it leading into a pregnancy, in other words, before you fall pregnant and during the pregnancy itself. And I've got no doubt that using a pump during pregnancy and leading into that is definitely of benefit. I think you can get tighter control with less concern around low blood sugars or hypoglycemia. And that benefit's even more marked if you're able to wear a continuous glucose monitor at the same time. You don't necessarily have to do that to see at least some of the benefit. The issue around being scared of change, I think we're all scared of change to some extent. I think we get comfortable with what we're doing. But perhaps the best way to answer that is say that with the appropriate support of your clinical team, most patients that we've switched across to pumps who've had diabetes for a long time, i.e. years or decades or whatever it is, will tell me that they have absolutely no doubt, having made the switch, that their diabetes is better. It does take a little bit of how they describe as headspace adjustment in terms of wearing a pump all the time. But once we get over that issue, and once we work through that and they accept that, they're very, very comfortable in using their pump. I've done several hundred pumps over the last 5 or 6 years of conversions of adult type 1s to pumps, and I've had 2 stop. Neither of them were for more poor control. In terms of the other piece at the top of the question, how difficult is it to use a pump? So I'd suggest that if you're capable of testing your blood sugar and you're capable of operating a mobile phone, then you're very capable of operating a pump. It's no more complex than that, as long as you receive the appropriate training. What does it do for your control? The overall blood glucose control is usually improved. If you measure that by an HbA1c or the 3-month blood test, as some people call it, or the average glucose, as some people call it, you may not see dramatic improvements, although in some patients we do. But because the risk of low blood sugar or hypoglycemia is so much less, and I think that's the best benefit for patients on a pump from my perspective, from an endocrinologist perspective, most people get some HbA1c reduction. In our clinic, we see about a 1 to 1.5% improvement on average, with a range of between about 0.5% and all the way up to, I've got some patients who've had 6 or 7% of HbA1c improvement. Those are usually people who've really struggled with needles. I think there is a convenience addition by being on a pump. I think it'll calculate your bolus insulin for you when you put the carbohydrate and the blood sugar levels in. I think it enables you to adjust your basal insulin as you need to. You're able to program it and to deliver accurate amounts at the right time. And I think overall that is more convenient, certainly in my opinion. The pain, it's no more painful than giving yourself an insulin needle. And as Gareth has already said tonight, there's a lot less in needles than there were using multiple daily injections or even twice daily needles with premix insulin, if that's what you're using. Occasionally you might put a needle in that might hit a nerve or something, and that might be more painful than others. But overall the pain is no worse. So if you're already using needles, I don't see that as an issue. And cost. Unfortunately, currently in Australia, for adult pumps at least, there's no reimbursement from PBS or Medicare. That's something that lots of us are spending a lot of time thinking around how to improve. At the moment, those people who are on pumps in Australia are usually funding them via medical insurance policies, and that will fully cover the cost of the pump and will allow you to purchase a new pump once the original one is out of warranty. Your monthly costs are in the order of about $28 to $30 after the NDSS has heavily subsidized the consumable cost of the pump. So it is slightly more expensive than being on needles, but long term, when you extend that out, I have little doubt is of benefit for most patients.
Great, thanks for that, Mark. Excellent answer. So just to remind everybody, you can still have a chance to submit some questions live using the Google Hangouts session. Tweet us or hop onto the Facebook page and send your live question. So back to you, Gareth. What are the great advantages to using this pump over other therapies?
Oh, well, great advantages. It really adds flexibility back to your life. It allows you to be able to give yourself really small pieces of insulin to cover, low carbohydrate meals. It allows you the flexibility of being able to go for a run or do some exercise and cut your basal rates in half to make sure you don't go low while doing those exercises. And, as well as allowing you to sleep in. The first 16 years without being on a pump, one of the worst things was, you couldn't sleep in, you couldn't wait not to do your insulin first thing in the morning because you had your long-acting insulin. But now, there's no real strict time frames in regards to when you have to eat and busy days at work and all that type of thing. So it is a great flexibility back into your life. Is probably one of the greatest advantages you can get.
Great, thanks for that answer. I might stick with you there, Gareth, on the next question, because it's probably something that's quite close to your heart with your daughter Shiloh. What would you say to people who are newly diagnosed with type 1 regarding pump therapy, I guess from your experience and with your daughter?
Quite simply, that just not to be scared of it. I've got a lot of friends who swore they would never go on a pump. They said they had good control with their MDI, and obviously I had my daughter diagnosed 2 years ago, and it was funny. They swore they'd never go on the pump with my friends, and then after going on a pump, they tried to work out why they didn't do it sooner. So it's been a great change for them. In regards to my daughter, I wasn't prepared to leave the hospital without her being on a pump. Seeing my wife, who has a needle phobia, have to hold her 2-year-old daughter and give her first needle in the hospital was heartbreaking for me, heartbreaking for her, and I wasn't prepared to see that happen 5-6 times a day. So it was, first thing to mind is to get on a pump and make sure everything works well from there.
Great, thank you for that answer, Gareth. Just another reminder, feel free to send through your live questions using the Hangout session. You can tweet us with 640G webinar or hop onto our Facebook page. So just jumping back to you there, Mark. I'm nervous about using the device accurately. How will I learn how to live with a pump?
Look, I think this is not something that I think should concern people. I think, if anything, the pump will increase accuracy of managing diabetes, and certainly to my experience does in everybody who goes onto it. As I've said previously, provided you test your blood sugar on a regular basis, and that you record that blood sugar in your pump, and some of the pumps will allow you to the blood glucose meter to automatically go into the pump. You don't even have to manually enter it. And provided someone runs through how to carbohydrate count with you, and if you're on multiple daily injections, a lot of people are already doing that, and certainly should be. The bolus calculator that the pump has built into it will very accurately calculate bolus insulin doses for meals, including any correction to bring down any high levels, or even it'll omit insulin when it feels the sugar is too low, or omit some of the insulin to correct you back up to a more appropriate value. You can set the targets in the pump for blood sugar that you want, and we can adjust those ratios of insulin to carbohydrate and correction as we need to. And that's in my opinion is the role initially of the clinical team, and then to provide any patient with the tools and the knowledge to be able to do that as they need to. Gareth's already mentioned that you can adjust your basal rates according to what you need to do, and it's a relatively simple process to do. So I'm not concerned about accuracy, and most patients do better on it in terms of accuracy. They do need to test their blood sugars. About learning to live with a pump, again, we've touched on this. It is a change, but most people seem to adapt to it very, very well, and are able to accept it without too many worries when they realize how much benefit it's providing them in terms of flexibility, control, less hypoglycemia, and all the other benefits we've already mentioned tonight.
Great, thank you for that answer, Mark. Across to you, Gareth, the next question. What can you do on a pump that you couldn't do when just using injections?
Look, I think this is you can still do everything when you're doing MDI, but I think it's just easier to do it on a pump. As I mentioned before, doing exercise for myself, I go to an exercise boot camp, and what I do is I then shut off my insulin to be able to do that exercise for that hour, because I know I just won't need it because I'll be working hard enough to be able to maintain it. Obviously, when I was on long-acting insulin, I couldn't do that. You couldn't just turn it off and hope it works. So that is a great benefit. What I also can do, and this is more from a mindset, is I can send my daughter to kinder or school knowing that we can set her rates at a lower level because she'll be more active at school and kinder, and know that she'll be fine. Obviously, teachers have had training from ourselves and our team. However, we know we can adjust things to make sure it suits her throughout the day. And basically on MDI, we wouldn't have been able to do that so easily and readily by ourselves.
Yeah, great. Thanks for sharing that, Gareth. So just a reminder about submitting your questions. Feel free to do so on the Google Hangouts, tweet 640G webinar, or join onto our Facebook page and write a comment there. Just sticking with you, Gareth, on the next question. It's a bit more of a practical question and a great question in itself. Do you find it inconvenient for sleeping? And if you want to go swimming, sex, etc., do you find the pump to be obtrusive, given that it's attached to your body?
Honestly, after the first, I suppose, day or so, I forget that the pump was even there. It just becomes part of you. Obviously, it's there 24/7. But going swimming, you can still disconnect. You just disconnect it from your body for an hour or so, do what you need to do, and then reconnect. Obviously, as Mark said, you still need to test your blood sugar levels to make sure that you're staying within range. But you don't have to have it on 24/7 if you're doing other things. When I was younger, I used to play baseball, and I would take it off during times at baseball, and then put it back on, or put it back on in between innings. So it really is great when you've got it on, but it's not so strict that you can't do other things with it.
Great, appreciate that answer, Gareth. Across to you, Mark. How accurate is the CGM, the continuous glucose monitor? I would hate to see the pump suspending a hypo when actual BGL is within range, just to result in a hyper. What are your thoughts on that?
Look, good question, and an important question. And before I kind of directly answer it, I got asked a question the other day around what do I think is the way forward in technology, and what's going to best benefit our patients. And without doubt, I think it's continuous glucose monitoring, or CGM. The pump and the insulin delivery we've spoken about already, but having the ability to not only know what your blood sugar is every 3 to 5 minutes, but being able to feed that information directly into a pump and now begin to adjust the insulin settings from a patient's perspective, provided it's accurate, and that's where we get to this question, I think is a huge way forward. So how accurate is it? It's getting better all the time. I don't, off the top of my head, have exact numbers for you, but you're not going to have, it depends on what your value is, but you're not going to have whole or 2 or 3 millimole per liter differences in between your finger prick and the meter. You do need to bear in mind that there is from a technical point of view, there is we measure the glucose in the CGM slightly differently to you do compared to a finger glucose measure. But for most patients, that's irrelevant. When you do a CGM, it measures what we call interstitial glucose, whereas your finger prick is capillary glucose levels. There's a bit of a difference in the timing of when the glucose peaks and troughs, but as I said, it's really not a significant clinical issue in my experience. The question also mentions that you can on the Medtronic device both the current version and the version prior, you can suspend insulin, or the pump can suspend insulin when it reaches a certain level, and on the 640G it can begin to prevent hypoglycemia, not just soften the blow, as it were. And this has been tried and tested and proven and tried in clinical fields again and again and again and again. And there's almost no cases of inappropriate suspension of insulin because the blood sugar is within the normal range. And you don't then, when you look at all these patients that have had this trialed on and subsequently using it in the real world out there in your homes, in your workplaces, in your schools and everywhere, people don't end up with high blood sugars or hypers afterwards. The sugar gets pretty close to the normal range, and remember that the maximum time it can be suspended for is 2 hours. And Gareth's already told you that, you know, we encourage patients to come off the pump for an hour or 2 hours at a time for swimming and other activities where the pump will be prohibitive. So this is a tried and tested, and it's not an issue. And the CGM accuracy is good enough now that I certainly have no concerns from a clinician's perspective.
Great, thanks for that answer, Mark.
Can I just add something to that one just very quickly? I've been, myself and my daughter, I suppose, have been on the CGM for the last, or since January, on the new 640G, where it actually predicts the lows. And one of the biggest things that we've found between the last version of CGM and this version is how close it is. We have been able to eliminate, I suppose, around 90 to 95% of any major hypos that my daughter and I are having, just through this technology and how close it is. It is usually within 1 millimole on the system, and that's been going, you know, for the last 10 months. We haven't had a problem. Especially at kinder, this really does allow you to have a surety that you can do what you need to do, and your children can do what you need to do, and have the security that it is going to stop anything from happening. Obviously, there are still, you know, extensive circumstances that there's still 5% worth of hypos, but there's still a user in that whole situation where you need to manage that piece as well. So it is it is a great technology, and I agree with Mark, it is getting better and better.
Great, thanks for that, Gareth. And while we're on the topic of CGM, how have you found it with Shiloh and being at school and teachers, etc., knowing how to use the technology?
It's been great. I'll put it this way, we refuse to send Shiloh to school or kinder without the CGM on, because it gives so much visibility to the teachers that all they need to do is know that it's on and can be able to look at the screen within a heartbeat, because obviously there's 20 other kids there that they need to maintain. So they have been able to learn to look at it, understand it, and act appropriately when something needs to be done. So it has been great.
Excellent, thanks for that. Just on to the next question, and another practical question will remain with you here, Gareth. Are you connected to the pump 24/7? Would pockets be required in all clothing or two-piece clothing? How about if you want to wear a dress? You may not have the dress wearing experience, but I'm sure your daughter has. What are your thoughts on this question?
So predominantly yes, connected 24/7. I obviously, just being a guy, I just wear it on my belt for work all the time. I constantly get asked, wow, that's a really old MP3 player or something crazy like that. However, yeah, it is there or in my pocket. My daughter and my friends, female friends, they do wear dresses. Some of them have the neat capability of being able to put a little hole and a little pocket into their dresses, or some of them, you know, put it into their bra, or they actually get specially made belts, like garter belts and that sort of thing, to be able to put their pump on. So there are plenty of companies and people out there now who are making it easier and easier to be able to put your pump somewhere where it needs to be, where you can still access it and live life to the fullest.
Great, thanks for that. And we'll move on to the next question. Mark, if you could start, and we'll get Gareth to answer this one as well. What would be your advice to parents whose child is newly diagnosed with type 1 regarding pump therapy? How easy is it for a child to use?
So I've got to agree with Gareth, and I'm going to answer this as a parent. I don't have a parent with diabetes, and I'm not diabetic myself. But if one of my kids developed diabetes, I would insist on them being on a pump without doubt. I think it's the closest you get to normal physiologic delivery of insulin. And that's spoken from somebody who's treated people for diabetes for 15 years and done it in many different ways. There's a lot to learn for a child or for parents if the child is young enough that the parents need to do it for them. I do think you need to individualize the decision. I don't believe you can force a pump on anybody, nor should you. And obviously it depends on what age the child is. I spend quite a lot of time with teenagers with diabetes and young adults, and I think they need handling in a slightly different way to a young child, such as Gareth's daughter did, when largely it's a parent's decision. How easy is it for a child to use? Gareth can probably answer that better, but the kids that I see running around the pediatric clinic when I go and visit certainly don't struggle and are probably better than some of the adults on it and do it fairly quickly.
Great, thanks for that. And your thoughts on that, Gareth, being very relevant to yourself?
Oh, look, I think today's kids are foremost up on the whole technology piece. I mean, they can get into my iPhone and my iPad and know how to jump around it. And it's the same with the pump. My daughter is, 4 now? So obviously when she was 2, we did absolutely everything. But now we're in the process of starting to get her to press the buttons, if you like. Obviously it's going to take her a long time to understand the full process around the carb counting and all that type of thing. The pump itself is very self-explanatory. As you flow through the screens, it gives you prompts on what you do next. Now, we've also then gone and taught our teacher how to do it, and she's never had anything to do with diabetes previously, and she took it to it within a few days. And we've also taught other family members to be able to manage it, who, to one sense, are technology illiterate. But once again, you go through a process, and you'll always be there to be available for questions through your team or the other people. And
great, thanks for that. We're just about out of time, but one more question. We'll get through to you, Gareth, on this one first. How many hypos do you get now, and how do you treat them? And we'll go to Mark from an endo's perspective. Do you have any patients, and how are they experiencing hypos, and how do they deal with them? But first to you, Gareth.
Yeah, as I mentioned before, it's probably about 95% of my hypos with the predictive technology have been eliminated. Otherwise, I still treat them the same. If I'm shooting low quickly, then I'll have the 15 grams of carbs and just keep track of how it's going and watching the CGM as it comes back up. If it is just a mild low and it's picked it up nice and early, I actually won't do anything. I'll let the pump do itself, because what it does, it predicts it before it happens, and then it turns back on again as you go. Anything with diabetes is with you for life. So if you've got 100% focus on it while you live life, you can manage it and treat it how you need to, and each situation is going to be different, I suppose.
Great, thanks. And your perspective, Mark, from a doctor's point of view?
I think the number of hypos are less, as Gareth has said. I've regularly said in various forums that the best advantage, or for me the single biggest advantage, certainly in adults, is less hypoglycemia and very little severe hypoglycemia. I would say that most patients tell me that their hypos feel different on a pump to how they do on multiple daily injections. Their symptom complex is perhaps not as obvious most of the time. And I think that reflects what Gareth was mentioning. If your glucose is dropping rapidly, you'll have more severe or acute symptoms, and you'll be more aware of it. If you are gradually drifting downward, I think your symptoms are not quite as severe. So patients occasionally take a little while to adjust to that. But once they've worked that out, it's no different. And then, as Gareth has said, if you do have a hypo, I think the treatment is no different in terms of what you should give if you need carbohydrate. Doctors, nurses, and patients certainly previously have traditionally overtreated hypoglycemia. We've given far too much carbohydrate, and you've ended up with a rebound hyper of 15, 20, 25 millimoles per liter, and you end up chasing your tail. So you don't need as much carbohydrate as you think.
Great.
Yep. The first hypos that I have ever had in the 26 years is when I was on long-acting insulin. And then when I went to the pump, as Mark said, the hypos changed dramatically. So it is a much better way of going.
Great. Thanks for that insight, Gareth. So we've come to the end of our session here. I'd like to thank our guests, Gareth and Mark, for joining us tonight, for taking time out of their busy schedule. So thank you both, gentlemen, for coming along this evening.
Thank you.
Thanks for having us.
And just as a reminder for those of you who are viewing, if you'd like to get in contact with us, here are a few contact points. Please give us a call on 1-800-777-808. Our website is medtronicdiabetes.com.au, or you can follow us on our social media profiles on Twitter, Instagram, or Facebook. So thanks everyone for joining us tonight. Hope you have a great evening, and speak to you soon.